Hello, and welcome to Digest This, where we discuss clinical issues in gastroenterology. My name is Francesca Moroni. I'm one of the gastroenterology trainees in the north of Scotland. Today we are discussing gastrostomy tips and tricks, and I am delighted to welcome Dr Alastair McKinlay, a consultant gastroenterologist in Aberdeen Royal Infirmary and BSG President-elect. Welcome, Dr McKinlay, and thank you for joining us today.
Thanks, Fran.
So on the back of the Sir Francis report, unfortunately, malnutrition became a much more hot topic in hospitalized patients. But I wonder if you can tell us, how do we recognize and what assessment tool we have?
I think you're referring to the Francis report, which was the mid-staffs report. And it's worth remembering that it was a lot more than just nutrition. It was a lot about nursing standards, how we care for people in hospital. But certainly Lord Francis noted that people's nutrition wasn't being looked after, and it was the same old story, food being put down in front of people who couldn't eat or swallow, not being helped with menu choices, not being helped to eat. And patients and their relatives know that food is necessary for life, so they get very worried, quite rightly, when this doesn't occur. It's the same story that we heard when we did the food, fluid and nutritional care standards, originally back in about 2003, and these standards are still, they've been revised, they're still considered to be Scottish policy, and if you obey the food, fluid and nutritional standards, we should avoid having a mid-staffs in Scotland. When a patient can't eat, I always think it's important to, or when their nutrition is failing in hospital, to try and think through why this has occurred. And very broadly, there are three patterns which lead to people being unable to eat. The first is loss of appetite, and that is very, very common. It's associated with illness. It's something that we should expect. And very often patients can be helped by a good dietitian, for example, or by careful nursing, being offered food, perhaps being offered fortified food if appropriate, or often within a hospital context by oral sip feeds, which contain a higher level of calories per mil than they can get just from food. So if somebody's intake is very limited, oral supplements will provide them with a complete calories, protein, carbohydrate, fat, and their micronutrients in a much smaller volume, and can be very, very useful. I have a general rule. I always, when it comes down to supplemental feeding, I work with my dietetic colleagues. They are the experts. And if anything came out of this particular talk, it was, by all means, work with your dietetic colleagues and involve them early. I think you also asked about how do we assess people. I think the first thing is obviously to talk to patients, but the MUST screening score, Malnutrition Universal Screening Tool, is the one that has been recommended for Scotland. And it is not a nutritional assessment. It is a screening tool to pick up malnutrition. And it involves looking at the BMI, so people have to be able to measure height and weight and calculate a BMI, and then looking at weight loss, and finally looking about whether somebody's had anything to eat over about the past 3 days. And you can put that together to get a score, and anything over 2 indicates a fairly significant risk of malnutrition. So again, get in early, don't wait for it to continue day after day. And malnutrition remains common. The figures still suggest about 30% of people coming into Scottish hospitals are either at high or medium risk of malnutrition, and that without intervention their condition will often get worse, not better. So it's still common. If you go to specific groups, anybody transferred from another hospital, the rate of malnutrition is higher, probably because they're iller. And slightly worrying, anybody coming in from a care home, the rate of malnutrition in patients admitted from care homes has been put as high as 40%. So one should be aware, one should act early.
You touched about nutritional supplements. So what do we mean by this, and also what choices can we make to best serve our patients?
Well, nutritional supplementation typically refers to oral nutritional supplements, or ONS. There are many, many different brands, and there are also national contracts within Scotland. So the best people to talk about in your hospital are to speak to your dietitians. And the range is huge. Most of them are complete. There are specialized nutritional supplements. Some are semi-elemental, for example. Palatability tends to go down the more specialized a supplement is. There are many, many different flavors, and there are also supplements designed for particular problems. So there are supplements which are designed, for example, for renal failure. So I don't carry this information. I think amateur expertise is bad under any circumstances. So whilst I would still view myself as having a specialist nutritional interest, I always take advice from my dietitians. I think the important thing is to describe the problem and to try and work with your dietetic colleagues so they know what you are trying to address, and then to listen to what they say.
To go to the core of this talk, how do we choose which patient is appropriate to undergo a gastrostomy feeding procedure?
If you look at patients who've got a nutritional problem, and very, very broadly, you can divide them into three groups. Those who have diminished appetite, very, very common. We've discussed some of the issues for them. Those who have problems of access, so they have a functional gastrointestinal tract, but for some reason they cannot access it. The one that jumps to mind are things like strokes, but it could be upper GI or oropharyngeal cancer, for example, radiotherapy, motor neuron disease, which is one of the most difficult groups of patients to manage. So the gut will work if it can be fed. The problem is that you can't get calories, nutrition into the patient. The smallest group and the most complex are those with intestinal failure, where they actually cannot absorb or cannot handle, digest and absorb the nutrients. And they're a much rarer group, and they're a completely separate issue for a different day. So in a patient who's got a functional GI tract but with difficulties of access, or whose appetite is so disturbed by their illness that they simply cannot take the calories, then enteral feeding is the route of choice. And that could be through a nasogastric tube, or it could be if feeding is required for a longer period of time. We would typically say 6 weeks or more. Then you might want to think about a gastrostomy under those circumstances.
And so if we receive a referral from a different specialty to ask to place a percutaneous endoscopic gastrostomy feeding, what things should we keep in consideration before putting the patient through the procedure?
Well, we actually have an electronic referral, simply because it's quite a list of things that you'd want to know. But first of all, you want to know what the underlying diagnosis is. You also want to know whether the patient has already had supplementation with, for example, a nasogastric tube. And you want to get some idea about what the prognosis is. Diagnosis is important. Typically, for example, patients with dementia, we would have quite a lot of thinking before we would just leap in with a gastrostomy tube in that group of patients. A patient with motor neuron disease, one would probably want to try and get in as soon as possible before the patient becomes very, very weak, because we know the risks increase. So what's the diagnosis? What's the prognosis? What's the purpose? Patients can be being fed for with a curative expectation, or it may be palliative. Both are valid indications for feeding. It's useful to know if the patient's had any previous upper GI surgery. That can make life a bit more difficult. And then there are some very simple things. What's the MUST score? What's the risk of malnutrition? Have they had a proper dietetic assessment? And for many patients, have they had a speech and language assessment as well by a speech and language therapist? Moving on to the other technical things, you want to know about whether there is, for example, any ascites. Ascites is not an absolute contraindication to putting in a gastrostomy tube, but it should make you think very, very hard indeed. It poses very significant risks. First of all, you may not be able to reach the stomach, but much more worryingly, you may not get a seal between the stomach and the abdominal wall, in which case you'll get leakage and peritonitis. So ascites, very important. The presence of infection, particularly things like an upper respiratory tract infection. We know, for example, that raised CRPs are associated with a worse outcome, more complications in gastrostomy. That can be important. Very simple things. Is the patient on warfarin? Quite often they are if they've had a stroke, for example, and clopidogrel. Now, rightly or wrongly, we have a particular thing about clopidogrel, and that's based on observation, because I've seen patients who've been off clopidogrel for a couple of days still develop a great big hematoma on the gastric mucosa just with the local anaesthetic going in. So clopidogrel, I think you do need to watch. Very small point, we very often will reverse sedation in our patients. These patients are very, very vulnerable to aspiration, and not based on any particular evidence, but we usually reverse as much sedation as we can to get them sitting up and as conscious as possible. And it's worth knowing whether there's a history of epilepsy, because you may want to be cautious about flumazenol. I think it really does suit a kind of ordered approach, and that's why an electronic referral often makes sense, because you get that information.
In terms of what choices of feeding tubes we have when we think about placing gastrostomy, would you like to discuss some of the options?
Right. I think the first thing I would say is that very often we quite like people who have had at least a go with nasogastric feeding before we launch into gastrostomy. Very important with stroke, and generally speaking, the advice is try not to avoid going to gastrostomy for at least 6 weeks, because people do recover. And in fact, they may require a nasogastric tube to begin with, but be able to be weaned off. So perhaps a 6-week gap before you go to gastrostomy is not a bad thing in stroke patients particularly. With nasogastric tubes, again, with the patient's permission, bridles can be very, very useful if the patient keeps accidentally or unintentionally removing the tube. So worth exploring those things first. When it comes to the actual choice of gastrostomy tube, I think you go with what you're familiar with. Generally speaking, for a first gastrostomy, we would usually put in some form of disc gastrostomy. And it doesn't really matter whether you go for the Freaka peg, which is very solid, has a really good bumper, very, very unusual for anybody to be able to pull out a Freaka peg, so secure, usually quite tough as well. There's Core Flow, also a very, very good kit, and a whole variety of others. If I have a personal preference, it's for something that cannot be easily traction removed. One of the most serious complications is a peg that traction removes itself out of the stomach and into the peritoneum early on after placement, and that can be very, very serious indeed. So for us, usually it would be to place a disc gastrostomy. Now, sometimes there are reasons why you might not want to do that, and the classic is people with malignancy of the upper GI tract or the aeropharynx, because there are reports about tubes picking up tumour cells on the way down and then implanting them into the tract. Now, it is very rare, and I don't think we've actually seen it here, and my experience probably goes to over 3,000 gastrostomies over the years. But there are well-documented cases, and there are several cases of people who had curative treatment, but whose metastatic disease was caused by the placement of the peg. So in some of those patients, we would perhaps prefer to go for a GASTROPEXI and an insertion of the peg from the outside in, so you don't pull down past the tumour. The other time it can be very useful is if you've got a patient with a stricture or with obstruction in the aeropharynx or upper GI tract, because all you have to do there is to get a nasal scope down, and then you can do everything from the inside without having to pull the tube. So GASTROPEXI, a very, very useful technique, and my colleague Emma Metcalf, who's meticulously audited our own experience, has shown that our complication rate with GASTROPEXI is no higher than with a straightforward gastrostomy placement. It's whatever you're familiar with. If we use the Kimberly-Clark kit, nice introducer. There is a definite learning curve with GASTROPEXI. It's not something you should just launch into on a whim, but can be very effective, particularly in this specialized group of patients. After that, what you replace a gastrostomy with really should be a discussion between you, the patient, and or their carers as to what suits them.
We talked about inserting percutaneous endoscopic gastrostomy. What are the complications during the procedure or immediately after?
Well, during the procedure itself, I think probably the most common complication is simply failure to find a safe site. And I think one should never be afraid of just stopping and saying, I'm uncertain if this is safe. So the clues there: do you get good transillumination? Is it possible to get a continuous and useful inflation of the stomach, so it comes up hard against the abdominal wall? Do you get a good finger indent? And then very, very importantly, when you put the local anesthetic in, what's the depth the needle has to go through? And we do the air pull test, where the nurse who's usually putting in the gastrostomy pulls air when the needle goes into the stomach, and then watches very, very carefully as it's withdrawn to see if bubbles appear. Bubbles should only really appear once the needle comes out of the skin, and if bubbles appear halfway out, you may be going through small bowel or colon. And we've seen this, and we've actually seen a positive air pull test on a number of occasions. Getting good inflation is probably the best way of doing things securely and safely. You push everything else out of the way by and large. So, not finding a site, stop. And then get a CT, do some form of imaging, work out where the stomach is. It may be completely in the chest, it may not be possible, but stop if you can't get a good site. The only exception we would have with this is if we're at the stage where we've got the cannula in, we've passed the wire, we've taken it out through the mouth, and we've got the peg tied on the end. You're probably better finishing, if at all possible under those circumstances. You've already made the holes. It's much safer to get the peg in and get everything tightened up than to leave people dangling around with holes. So, unable to find a site. Infection, we would always give antibiotics, a broad spectrum antibiotic, as per operative cover, a one single shot before doing a peg, and our infection rate is very low. Key things to watch there: has the patient got some form of chronic infection in the upper GI tract or the respiratory system? Typically, people who've got very, very severe Pseudomonas, sinusitis and so on can pose a real problem with colonization and infection. Bleeding, remarkably rare. It's quite common to get bleeding at the time that the cut is made for the peg. It can all ooze a bit, but usually the peg and its bumper compresses everything and stops bleeding. So bleeding is quite uncommon. Pain is very common. In fact, we didn't used to think people got a lot of pain from pegs, but that was because when I started, most of the patients we were putting pegs into couldn't talk. They'd had strokes. When you actually talk to patients, this procedure can be quite painful, and you should anticipate that. Make sure they've got analgesia. We also have a policy that if people have unexplained pain and it's not settling, that we get a CT scan. And again, just a tip here, a word of warning. If you just go for a plain chest x-ray and abdominal film and you've put a peg in, there will be a pneumoperitoneum. If there isn't, you probably haven't done something correctly. It happens inevitably. And the other problem with that kind of two-dimensional imaging is you cannot tell where the tube has gone. Even if you do a tubogram, it will tell you that the tube is in the stomach. And if the tube isn't in the stomach and you've just done an endoscopic gastrostomy, there is something very badly wrong. The only way to work out exactly where the tube has gone, has it gone through another organ, for example, or small bowel, is CT scanning. So it should be cross-sectional imaging, not two-dimensional imaging.
What about long-term complication of PEGs?
Well, by and large, if people, after 6 weeks, it's really serious complications are rare, but lesser complications, which nevertheless can be very distressing for the patient, are not uncommon. Pain at the site, occasionally, particularly if you've had a slightly traumatic insertion. One group to be aware of are patients with cystic fibrosis, where coughing during the procedure is common, and where you actually may traumatize the tract in the process of putting it in. So pain sometimes is an issue, but for most people pain settles, particularly when the peg loosens off. Local infection, very common, typically with things like Candida, Staphylococci, the common things you would expect, and usually as presenting as discomfort in the peg site. Not severe pain, but usually a discomfort and irritation in the peg site, and most of the time it will be Candida, and very often it's associated with overgranulation. So they all often go together, and the key things there are treat with some form of antifungal, usually fluconazole, can be fluconazole cream. We sometimes use golden eye ointment. This is not licensed, I should add, but it sometimes is helpful for bacterial infections. Treat the local source of infection, and if it keeps coming back, consider a routine change of the PEG tube at that stage. And for overgranulation, all sorts of things. You can use hydrocortisone cream, but in fact, if it's prominent overgranulation, then using an APC catheter on the outside just to cauterize the area of the overgranulation can be extremely effective. You've got to keep it off normal skin. It tends to be painless if you're treating the overgranulation, but if you stray with an active APC onto somebody's skin, it's like having a red hot needle put onto it. So sometimes local anesthetic or EMLA cream roundabout can be useful as well. The most serious complication, particularly of disc gastrostomies, is the buried bumper. And this usually occurs if the bumper has been kept too tight or has been kept under traction. And the keys to a buried bumper, remarkably little to see from the outside. Usually the skin is intact. It can sometimes be very clean because people have meticulously cleaned and tightened the tube up. But typically the tube doesn't move freely. It won't go in and out. It doesn't rotate. And the symptoms of a buried bumper are usually that the tube has been requiring a bit more pressure to feed, and then it suddenly blocks and becomes horrendously infected because horrible white pus keeps coming out around the tube, pus that smells suspiciously like feed. And it's the feed coming in, being unable to get to the stomach, coming around the side of the tube and then emerging out beside it. And a buried bumper is quite an exercise to remove if it occurs.
Who manages patients with feeding gastrostomy in community in the long term, and what is the role of the gastroenterologist in this?
Well, most of the care in the community in Grampian is done by our colleagues, the homeward nurses, and we have a multidisciplinary team meeting every week where we discuss patients who's running into problems, who requires tube replacements, so we can sort out what's going to be best for the patient and offer them, for example, a change of tube if it requires that. We also have a community dietitian who deals with enteral tube feeding in our patients. Important that patients are assessed to make sure that they still need to be fed. I think I have a particular bee in my bonnet, which I appreciate, but I think if you do PEGs, you should really set up a service to look after the PEG. And I think we should move away from a situation where everybody does an occasional PEG and then out of sight, out of mind, discharged out to the community. I don't want anything to do with it. I think if you put in a PEG, then there should be some service so that patients can be looked after and their problems dealt with. And again, slightly controversially, we replace usually our tubes at about 2 years for disc gastrostomies, simply because by that stage, if they've been used, they're tending to get a bit grubby, and they also lose their plasticizers, so they become much more likely to kink or show tube damage. You can get fungal growth on the inside of a tube. So at about the 2-year mark, we will replace electively. And if you're going to do that in an ordered way, you need a service. You need to know who you put PEGs into. You need to know what the outcomes are, and you need to have some kind of multidisciplinary approach to them.
For the benefit of the gastroenterology trainees, we often get phone calls from the emergency department about a patient with a feeding gastrostomy, and the usual phone call is the PEG is fallen out. So what information should we gather before launching in to do any intervention with the patient at the bedside?
Well, first of all, disc gastrostomies falling out on their own is very, very unusual indeed. So it's usually balloon gastrostomies. And the first things to know are when did it go in? Because there's a world of a difference between a balloon gastrostomy that was put in 2 weeks ago and has now come out, which can be quite a formidable replacement problem, versus one that has been in for 3 years and has now come out. Because with a 3-year-old one or longer, anything over 6 weeks, you've probably got a formed tract, and the sooner you get in and replace it, the better. The easier it is, the better for the patient, the less time they have to spend in hospital. So when was it put in? Next, do you know what type of gastrostomy it is? we make sure patients go home with a very clear description of what they have so that they know about it. But it's worth going straight to the endoscopic records to see if it's been an endoscopic placement, has the endoscopist stated what type of tube it is. In our experience, one of the problems is when they've been placed by radiology, it is not always clear exactly what was done, and sometimes tracking down who inserted the peg can be quite difficult. So if it's a balloon gastrostomy, you want to get in quickly rather than leave it. The longer you leave it, the more difficult the task is going to be. And if you're called to see a patient like that, then it's worth going down with, of all things, a set of suction catheters. Because suction catheters very conveniently come in graded sizes from very small all the way up to quite large. So if you're faced with a tract that's closing, you can take the smallest suction catheter. You are very, very unlikely to do any harm, and see if you can get it through the hole. And then you can try the next stage up and gradually work it up. It gives you some idea about how difficult putting a peg is going to be. If it's fairly straightforward getting the suction catheter in, then you can take a balloon gastrostomy. Patients will often have a spare, and then with lots of KY, just slip it in. If it doesn't go in, and this is not unusual, tracts begin to close very, very quickly, what can you do? Well, first of all, you're probably going to need a little bit of equipment, and it's very unlikely you're going to find that lying around in A&E. For example, you're going to need some form of guide wire, and you may even need to re-endoscope the patient. So probably you want to get them to an endoscopy room or to a unit or onto a GI ward. My own weapon of choice is the X-wire, which is a piece of ERCP kit. It has a hydrophilic tip. It comes in two lengths, the long and the short. For most pegs, you can just do the short. And if you just put that into the tract and twirl it, very often it will go straight through the tract. And with a bit of experience, you may be able to work out that it's gone through the tract, and then you can run a balloon gastrostomy over the top of the wire, and often with a bit of jiggling, it will go through the wire, just provides some stiffening. But if you're not at all clear that that wire has gone through, then you have to do some form of imaging. And for a gastroenterologist, often the easiest thing is to get on and to scope the patient and make sure that the wire comes out on the other side. If you're in that situation and you still can't get through the tract, you may have to dilate it. And again, the best weapon for that is a Savory-Gilead dilator. And we would start with the smallest size and just gradually work. It can be uncomfortable for the patient, but it's certainly much more comfortable than having a brand new peg. And usually you can open a tract with dilatation and get a balloon gastrostomy in. But knowing the wires come out the other side may be the rate limiting fact.
How are we certain then when we replace the balloon gastrostomy, we are in stomach with a tip?
Well, I should add one other thing, which is worth knowing it's a gastrostomy, because if it's a jejunostomy, it's a completely different kettle of fish. But in a gastrostomy, usually it's pretty clear that it will go through the tract. You can feel it go through. You can blow the balloon up. You can do this gently. There shouldn't be pain as you blow the balloon up, and you should be able to pull back and feel it under your fingers. And then ideally get an aspirate, and the same sort of rules apply as for nasogastric tube. If the aspirate is below a pH of 5, then you're pretty clearly in stomach. If you don't know for certain, and particularly if the tube's been out for a while, or if it's a very new tract and you're not sure about things, then a nasal endoscope or something really small, or just a conventional endoscope, and have a look down and make sure it's appeared on the other side. Take a photograph.
Do you have any tricks for unblocking pegs?
Well, I think the first thing is to make sure you're not dealing with a buried bumper, because if you're dealing with a buried bumper, no amount of force or anything will help you there. Unblocking peg tubes, the commonest reason for peg tubes blocking is they haven't been flushed. So it's getting usually an end-fit syringe and some water, and sometimes the pulse method where you just apply little gentle pushes on the syringe so you're pulsing the pressure will often help to clear things. You can, if you feel confident and you're happy that the tube is in the stomach, you can very gently pass something like an X-wire. You're very unlikely to do any harm. Another reason why the X-wire is my weapon of choice for these things. Sometimes an X-wire followed by pulsing it, you can clean out the tube. After that, people try all sorts of funny things. Coke, for example. I'm referring here to Coca-Cola, not to any form of narcotic, illegal or otherwise. But the bubbles are supposed to help. Citrus containing drinks and so on. Everybody has their own favourite. If absolutely you can't unblock the tube, you need to begin to wonder whether there is some issue about the tube position, and then it may be a case of having to have a look.
So to conclude, do you have any take-home message for the general gastroenterology looking after patients with gastrostomy feeding tubes?
I think my take-home message is that we've often been very, very cavalier in our attitude to gastrostomy placement. The attitude is that you try and fit it onto a list, you search around for somebody who may be able to do the other bit of the procedure, and then you do it and get rid of it as quickly as possible. And I don't think that's very satisfactory. I think we underestimate the mortality associated with PEG. If that was the attitude of an ERCP service, that you fit them onto the end of a list when you're doing a normal list, and that you just look around for a nurse who might know something about it, and you have a go. Haven't done one for a while, but I think I'll have a wee go at ERCP. You would quite rightly be hauled up by JAG or by whatever accrediting authority. This would be considered utterly, utterly unacceptable. And if anything happened to the patient, you would be in very, very big trouble. I think we need a similar attitude to gastrostomy. It should ideally be done by people who are used to doing gastrostomy, and it should ideally be done as part of a service where the indication is assessed properly and where some form of aftercare and service is offered.
Well, the only thing is left for me to say is to thank you for an excellent run through a very relevant topic, and to thank you for joining us for Digest This.